Hi, my name is Daniel Copeland, and I am presenting multiple muscle variations altering femoral nerve course and distal attachment of iliopsoas. A group of my classmates and I were working in the anatomy lab last fall, getting ready for our advanced anatomy course. We were looking for any variations that we thought were interesting or any dissections that were done well enough to be used as models for future anatomy courses. This is when I found the accessory iliacus muscle. After some research and further investigation of the muscle itself, I found out it was a muscle variation known as iliacus minimus. There's been a lot of research done on this specific muscle variation, and in all the research I found, iliacus minimus was a thin ribbon of muscle that interfered with the femoral nerve in some way, whether it be it pierced the nerve or it caused the nerve to split and go around the muscle. What set mine apart from all other cases of iliacus minimus was its size. My case dwarfed all the others. At its thickest point, which was around the top of the wing of the ilium, it is 92.73 millimeters, and the muscle tapered as it extended downward to about 32 millimeters at the point that it crossed over the femoral nerve. When cleaning the muscle to trace its insertion point, I noticed it fused with the iliacus before they inserted into the lesser trochanter. However, this fused muscle didn't fuse with the psoas major. Iliacus and psoas major inserted onto the lesser trochanter without the formation of an iliopsoas. While tracing the femoral nerve through the psoas major in an attempt to ensure that the nerve originated from the lumbar plexus in its typical way, I found an extra psoas belly. This additional psoas came from the same fascia that was part of the distal attachment of the psoas minor. This muscle traveled about 49 millimeters before it fused with the psoas major, which was before they inserted into the lesser trochanter. These variations are interesting cases with clinical implications. In a case where imaging can be performed, the accessory muscles can cause inaccurate readings or they can cause issues with identifying specific compartments within the pelvic region. Though I believe the more important clinical implication is the fact that the iliacus minimus crosses over the femoral nerve. This can cause a site of serious nerve compression, which in turn can cause pain and numbness in the area of compression, as well as any areas the nerve innervates after the compression. This can lead to treatments that don't actually affect the patient because it isn't actually treating the compressed nerve. Rather, it is treating other pathologies that could cause these same symptoms, pathologies that aren't actually there. So here's the issue. These muscle variations aren't identified until later through dissection. This leaves the patient with symptoms that are deemed untreatable. If possible, imaging could be used to identify these variations and find the true cause of the patient's symptoms. Hopefully, in the future, with the use of imaging, any compression by the iliacus minimus or other muscles can be diagnosed. That way, patients can receive treatment that properly addresses their pathology. Thank you.